Hello, everybody. This is Dr. Ashur. We are going to continue our series about pharmacologic treatments of heart failure. We started in the beginning with the pathophysiology of heart failure and the first part of drugs for treatment of heart failure. Today, we are going to continue the second part of drugs for the treatment of heart failure, which will start right now. Well, in this part of drugs in treatment of heart failure, we are going to discuss ACE inhibitors and angiotensin receptor blockers, their beneficial effects and mechanism of actions, as well as beta blockers and their mechanism of action. We talked before about diuretics. Today we are going to continue our talk about vasodilators with a specific attention to the angiotensin or renin-angiotensin aldosterone system antagonists, namely ACE inhibitors and angiotensin receptor blockers. So let us review the pathophysiologic mechanism of heart failure and major sites of action with a specific focus on the RAS system. Okay, so heart failure will be associated with decreased cardiac output, activation of the sympathetic nervous system. So the norepinephrine will activate, or epinephrine will activate the beta receptors in juxtaglomerular cells to produce renin, which will activate the formation of angiotensin 1. Through ACE, angiotensin 1 is converted into angiotensin 2, which will facilitate the release of aldosterone. Angiotensin 2 itself is severe vasoconstrictor. It also facilitates aldosterone release, as well as induction of cardiac remodeling, which include progressive chamber dilation, loss of contractile function, and ventricular hypertrophy. Let's go into more details about this topic because it's very critical in treatment of heart failure. So what are the pathologic effects of RAS in heart failure? So the story starts from the decrease in renal perfusion in heart failure patients. This will stimulate the renin release in addition to the beta receptors also by sympathetic nervous system from heart failure also. This will convert angiotensinogen produced by the liver into angiotensin 1, and through ACE produced by lung and renal endothelium will be converted into angiotensin 2. This is the core of most of the issues associated with RAS system in heart failure. So the angiotensin 2 itself can induce sodium and water retention. Okay, or reabsorption. It also induces aldosterone secretion, which itself also causes sodium and water retention. Okay. In addition, the angiotensin 2 itself activates antidiuretic hormone secretion, and this hormone also causes water absorption. All of these effects will increase the blood volume and increase preload. Okay. Angiotensin 2 itself is potent vasoconstrictor. So it causes arterial vasoconstriction, which can cause increase in the afterload. It also induces norepinephrine release, which can increase heart rate, cardiac output, and all of these will be deleterious to patients with heart failure because they increase also the afterload through the vasoconstriction, and heart rate will increase the oxygen demand in patients who are already lacking enough oxygen supply due to maybe coronary stenosis, coronary atherosclerosis, and other disease. Okay, I think that's it for this part. Yes, okay. Of course, if there is enough sodium and water in the body, this will inhibit the juxtaglomerular cell to produce more renin. So there is this mechanism self-regulatory. So in details, RAS plays central role in pathophysiology of congestive heart failure. Angiotensin 2 is potent arterial vasoconstrictor. It also mediates sodium and water retention, as we explained. In addition, it has these effects. It induces catecholamine release, as we said. It's also an arrhythmogenic, cause arrhythmia. It promotes vascular hyperplasia and myocardial hypertrophy. Remember, this is one of the remodeling mechanisms that can contribute to the development of heart failure. It also induces cardiomyocyte death, which also will contribute to heart failure. These actions contribute to heart failure and in many cases to pathologic remodeling of myocardium, leading to progression of congestive heart failure. That's why inhibition of angiotensin II is very important in the management of congestive heart failure. The first class is the ACE inhibitors. ACE, angiotensin converting enzyme inhibitor. The angiotensin converting enzyme is an enzyme that converts angiotensin 1 into the more potent angiotensin 2 and then to angiotensin 3. Both has similar effects. These drugs are preferential arterial vasodilator. If I dilate the arteries, this will give the heart more chance to pump blood into wide blood vessels. So this will increase the stroke volume, decrease after load, of course. This will increase the stroke volume and in turn cardiac output, because cardiac output is equals stroke volume times heart rate. They also reduce salt and water retention, because we said angiotensin II itself can cause sodium and water retention. In addition, aldosterone itself can cause sodium and water retention. Okay, so thereby they can suppress salt and water retention, and in this way they can reduce the preload. Okay, so they can reduce both afterload and preload. So when they cause or inhibit all the sodium water retention, they potentiate the effects of diuretics in congestive heart failure patients. They decrease sympathetic nervous system activity because they inhibit norepinephrine release. They decrease the long-term remodeling induced by angiotensin II, because they are going to inhibit angiotensin II on heart and blood vessels. Okay, this is responsible for the observed reduction in mortality and morbidity. Examples of these drugs that ends with pril, like captopril, enalapril, fosinopril, kenapril, and others. The second class is the ARBs, angiotensin 81 receptor blockers. These receptors, these drugs, they have similar effect to ACE inhibitor, but different mechanism. Okay, we'll talk about that in a minute. So similarly, they inhibit the action of angiotensin II to exert the previous effect that I mentioned. In addition, if you inhibit, so now angiotensin II has two receptors, AT1 here, and AT2. Okay, if I inhibit or block AT1 receptors, what's remaining is the AT2. So more angiotensin II will be available to bind to the AT2 receptors. AT2 receptors are counteracting or counteracts the effects of AT1 receptors. So they are, I mean, good in terms of treatment of heart failure patients. So this will add more advantage to the use of angiotensin receptor blockers. Okay. Their influence on mortality is similar to the ACE inhibitors. Okay. However, as we'll explain in a minute, ACE inhibitors, they also inhibit bradykinin breakdown. Okay, well, this has to do with whatever we're talking about. Bradykinin is, in one hand, good in treatment of heart failure because they are vasodilators, as we'll explain. But in other hand, they are inflammatory mediators that can cause persistent cough. So the ARBs do not have this effect on bradykinin, so there is no persistent cough induced by these drugs. Okay, so they are considered in patients intolerant of ACE inhibitors. Examples of all those ends with sartan, like losartan, candesartan, valsartan, and many others. So in details, the mechanism is here. Okay, the sympathetic nervous system activity, or the decreased renal perfusion will activate the juxtaglomeralar cells to produce renin. Renin will convert angiotensinogen to angiotensin 1. This could be inhibited by renin inhibitors like aliskiren. Okay, angiotensin 1 is converted into angiotensin 2 by the ACE. Okay, so I can inhibit this by ACE inhibitors such as captopril, enalapril, and many others. But these drugs also, because there is a similarity between the kininase and the ACE, they can also inhibit the kininase enzyme. Kininase enzyme is an enzyme that breaks down bradykinin into inactive peptides. What bradykinin are doing? They are they bind to the receptors. They induce production of nitric oxide, which again activates guanylate cyclase to convert GTP into cyclic GMP, and vasodilation can occur. And also they induce production of PGI2, prostacyclin. They are vasodilators. So anyway, at the end, they can induce vasodilation. So in one hand, angiotensin or ACE inhibitors can have this added effect of enhancing inhibition of breakdown of bradykinin. So this will increase or induce vasodilation, which will contribute or add to the effect of these drugs as vasodilators. But on the other hand, as I said, they can induce this bradykinin inflammatory mediator that can use persistent cough. Angiotensin 2 itself usually binds, this is the main receptor, which is the AT1 receptor. AT1 receptor. Through this one, it can induce the release of aldosterone. Okay, aldosterone can cause sodium and water retention. Through AT1 receptors, also angiotensin 2 can induce vasoconstriction, release of norepinephrine and sympathetic stimulation, cellular hypertrophy. As we said, this will contribute to the remodeling of the heart, and renovascular effects. As we said, itself it can induce sodium and water retention. So all of these effects can also affect the antidiuretic hormone and others. All these effects are inhibited by the angiotensin receptor blockers. So they will inhibit the binding angiotensin to these receptors, right? So these effects will be inhibited. On the other hand, also more angiotensin 2 will be available, so it can bind to angiotensin receptor 2, which inhibit the actions of AT1 receptors. Okay, so by so many mechanisms, it can also induce production of nitric oxide, cause vasodilation, also inhibit the sodium water retention, induce so many effects of AT1 receptors are inhibited by AT2 receptors. So they are the good side of the RAS system. Okay, they are regulating the activity of RAS on the cardiovascular system. Okay, now the last class of the drugs that are used for heart failure other than the inotropic drugs. So these includes the beta blockers. Okay, so beta blockers bind to beta adrenal receptors. Okay, and thereby, so beta receptors itself can induce, by binding norepinephrine to beta receptor, this will induce the production or the increased heart rate and contractility, and also inhibit the sympathetic effects on the renal juxtaglomerular cells to activate the RAS system. Okay, so this effect is blocked. Okay, so just let me correct that part. See, the beta blockers, they don't induce the contractility, okay, of the heart. The drugs that induce contractility are inotropics. We'll discuss these in the next video, inshallah. So most patients with chronic heart failure respond favorably to certain beta blockers, as we'll explain in a minute in the next slide. In spite of the fact these drugs can precipitate acute decompensation of the cardiac function, they have negative inotropic effect, because the beta induction or stimulation of the beta receptors cause enhanced contractility, right? If you inhibit these receptors, so decrease or negative inotropic effect. So this is the negative side. Okay, so in the beginning, they thought they will worsen the case of heart failure. However, this guy, Wagstein, in 1974-75, reported that beta blockers, specifically metoprolol, which is selective beta-1 blocker, okay? Beta-1 receptors are mainly in the heart, were associated with prolonged improvement of symptoms and exercise capacity in heart failure. This was kind of paradoxical and unexpected result. Initial response was a decrease in systolic function, so the negative inotropic effect, as reflected by decreased ejection fraction. However, after 2 to 4 months, systolic function gradually recovered and then improved beyond even the baseline level. As we'll see here in this experiment, they compared the metoprolol, the selective beta-1 blocker, with standard therapy. Metoprolol is the shaded one or the striped one, compared to the blue shaded one, the standard therapy. So this is the x-axis, the duration of treatment, and y-axis has the left ventricular ejection fraction. So as you see in the beginning, there was like decompensation, there is a negative inotropic effect, there is decrease in the left ventricular ejection fraction, until maybe 1 month. But after a couple of months, you see there is big improvement in the ejection fraction. Okay, so this was kind of a stunning observation by this guy in 1975. So studies with these drugs, specifically bisoprolol, metoprolol, nebivolol, all of these are selective beta-1 blockers. Okay, carvedilol is non-selective alpha and beta blocker. These drugs showed a reduction in mortality in patients with stable severe heart failure. But to add to the puzzle, bucindolol is also beta blocker, did not have this effect. So beta blocker, but so that's why the mechanism is not well known. But suggested mechanisms includes attenuation of or inhibition of adverse effects of high concentration of catecholamines on the myocardium, because they induce apoptosis, okay, because they induce they activate the caspases, the enzymes that are responsible for induction of apoptosis, okay, because these effects are mediated by beta receptors. If you block beta receptors, so catecholamines will not bind to these receptors, so there is no induction of apoptosis. So this one suggested mechanism. Also, the catecholamine can induce remodeling, okay, so they inhibit these effects by inhibition of beta blockers, so they inhibit the mitogenic activity of catecholamine. This is like this interesting study that says beta blockade in congestive heart failure from contraindication, they are contraindicated in the beginning to indication, published in 2006. Okay, that's it for now. Thank you for your attention, and we'll see you later. Have a wonderful day.